just going over the anatomy that we were talking about. Your upper anatomy includes the nose, mouth, jaw, oral cavity, and pharynx. And the larynx is our dividing line between the upper and lower airways. Typically right there at the glottic opening. Anything above the glottic opening is what? The upper airways. Anything below is the lower airways. Functions here is to warm, filter, and humidify air brought into the body. Now, what happens when we introduce an ET tube into that?
So the humidifying part.
We miss all this, don't we?
Yeah.
So why is it important for you to know that fact? Are you going to innovate? No, you're not going to innovate with an ET tube. You're not. But guess what? As an advanced EMT, you can maintain it. And once you take it over, who's responsible for it? You are. You'll actually also do even deep tracheal suctioning. You're not used to not be able to do that. But as an advanced EMT now, you can. And as an advanced EMT, you'll be running a ventilator. So you'll be maintaining it. So what would you do? Let me ask you something. What would you do if you're maintaining this ET tube and all of a sudden the alarms are going off and everything's going up and you figure that your estimation is that it is dislodged? So you're going to do what? You're going to take it out? Right? There you go, exactly. Go back to the basics, right? Put oral airway in, and then you may end up putting in combi tube or king airway or something. There you go. That's exactly the way I want you to think. Start at the basics, work your way up. Here we go. The pharynx is composed of the nasopharynx, the oral pharynx, and the laryngopharynx. We've all heard that, laryngospasms and all that, if you've got your medic partner out there that can innovate. So the nasopharynx, very important. There's a lot of action that goes on whenever you inspire. You know, you really don't think about what happens whenever you take a breath, because we just do it, right? We did it since, what, the second we were born? The first thing we did associated with life was that first breath, right? But inside the nose, we have these turbulence that whenever air comes in, the air just doesn't go straight into our lungs, does it? It goes in, it swirls around. And why does it swirl around? There you go. Humidifies it, warms it, and then another function too. Filters it. So that's why I have all that nasty hair up there. You know, you got the guys like me, and they got all that hair. It's frustrating, isn't it? Get in there and try to cut it down. Sorry, it grosses you out. Huh? You got it too, don't you? Okay. Just making sure, you know. So, and I also have the boogers up there too. I mean the mucus up there, right? It grabs all kinds of stuff. It's nasty. But whenever we use these advanced airways, we're bypassing all that. So, but is that going to have an effect on the way our patient responds? It can, because now we're cooling them. So remember, you know, we put in this emphasis all the time, and it's in these check sheets, and we always like, why are we so worried about putting a blanket on them? Well, we breathe, we've taken breaths in and out in the cold, right? What do you see? That fog? Because it's warm, right? Well, think about, you're missing all that. Now you're infusing cold air right into the core of your body. So what can your core body temperature do? So we want to make sure we try to, and if you're a trauma patient or an extreme burn patient, every little bit matters, right? Mm-hmm. And it will get to you. And all these little things that we can do to help preserve heat here, fluid here, and stuff will make a difference in the end. All right, so we have the oral pharynx. Oral pharynx is like our mouth. I like the mouth because I get to put food in it, because I like to eat, if you can't tell. And it is an alternate airway to the nose, but primarily do we breathe through our nose or mouth?
Nose.
Nose. But don't even think about it. It's just normal. I'm sitting here talking. I'm not breathing through my mouth as I'm talking. Air's coming in my nose. I don't even have to think about it. But after I've ran that 2-mile run that the Army used to make me do, how am I breathing then? It's like everything, right? If I could get air to come in my skin, I'd be like, give me some gills or something. So it is an alternate. So whenever you have a patient that's having difficulty breathing or respiratory distress, what might you see there?
They're unbreathable.
Yeah, they're using everything they can. They're moving forward, got that mouth wide open, especially the kids, right? You look in their mouth, what does their mouth look like? Dry as a bone, isn't it? Because the air coming in and out, it has a drying effect. So, also the oropharynx is the entrance to our digestive system. If it gets in, sometimes it, gets in through your nose. It's not supposed to. Sometimes it does.
You're snorting it.
You're snorting it, yeah.
I don't know who would do
Yes.
that, but
Well, it's possible. Sometimes it comes up your nose. You ever had milk come up your nose?
Ugh. My son
Or you're
used to do
laughing
that.
and Coke comes up, it burns, So, however, we got this nice little thing called the epiglottis. This helps prevent food and liquid from entering into the larynx when swallowing. So it covers up the glottic opening. And sometimes it can cause us problems. We use it as a landmark, but we also can get an infection there, right? And now we're seeing, because typically we think of that actually being something that happens to small children, right? But now we're seeing it happen to older adults. Where's my military medic? Military medic, right? Military? There's my military. Right? We used to not worry about it. Too much epiglottitis. Then we start seeing these younger military guys coming in that were never exposed to it as younger, so they've lost the immunity to it. And then you put them, where do you put them at? Huge hordes, don't you? Nice little breeding ground for germs. One gets sick and they end up getting it. Now we've got young adults. Same thing in college. First year college students. We worry about meningitis and epiglottitis now. As they go to college, and where do we put them?
In the dorm.
In the dorm room, small together. That's a nice little place. And jails, too. But usually jails, they're mixed in with older adults there, too. So it can cause us problems. And if that's a problem whenever we're trying to maintain an airway, maybe putting a supraglottic airway is not a good idea in there. And when I say supraglottic, what am I talking about there? Supra means what? Huh? Yeah, above. And glottic meaning? Yeah, that opening, right? Right there at the larynx. So if it's supraglottic, that means the airway's right above it, right? Here's the larynx, and we can find the larynx on ourselves by feeling for that thyroid cartilage, the big thing there, and it houses our vocal cords. And it is the narrowest portion. Now, in children, it gets real narrow in children. Used to be, and most of the time still, we won't use a cuffed ET tube in children. So if you have a medic, or if you're in a situation where you're transporting a child that has been intubated, that ET tube may not have a cuff on it, or it may have a cuff on it. If it has a cuff on it, you want to maintain a certain pressure on that cuff, because we don't want to cause the tissue to die. Tissue dying around the vocal cord is not a good thing in most books. That tends to lead like permanent problems. So it can be very narrow, where it's narrow enough to have an ET tube that is sealed, or in adults we typically have to have a cuff there. For you, as an advanced EMT, you can actually accidentally insert an airway into the trachea. Reason? We know this is because an ET tube, not ET tube, but a combi tube is a combi tube. Why? Because it has a combination. One is intended to go into the esophagus, the other one is intended to when you put it into the trachea, right? So it can happen. Now the king airway that we'll talk about is supposedly supposed to be virtually impossible to put into the trachea, but they say virtually, and that means
It's
it
open
can-
for mistakes.
Yeah. But if you ever try to mess with it on the mannequin, and we don't have a king airway, we'll have some hopefully by the time you come by. They're kind of pricey and hard to get. So I've got some that are about to expire at some services. They're going to give us some. But it is kind of hard to get them in, even with a laryngoscope trying to make it go in. Then we have the cricoid cartilage. This is separated from the thyroid cartridge by the cricoid membrane. It's that little indention that you feel. And that's like if you go to put it where, you see people that are going to do the tracheostomy, that's where they put it in. But for you, you may have somebody ask you to hold crate pressure, and that's what they're talking about. You're pushing on it. Perhaps now with the American Heart Association, we do not recommend that anymore. But there are some situations in advanced airway management where it may be necessary. Like if you're trying to visualize the vocal cords. We don't hold crate pressure to keep air from going into the stomach, but if your partner is trying to intubate and they ask you to hold crate pressure, the reason they're doing it is because they're wanting you to help them try to align the vocal cords so they can see it better. And that's still acceptable.